Welcome to this discussion of common or D-transposition of the great arteries. What we mean by transposition is that both great arteries arise on the opposite side of the septum from normal. This is from the Latin verb transponere, which means to place across. In this case, to place the great arteries across the septum from their usual location. That means that the aorta, of course, arises from the right ventricle and the pulmonary artery from the left. Keep in mind that transposition doesn't necessarily tell us anything about the anterior-posterior position of the great arteries. Most of the time, of course, in transposition, the aorta is anterior and the pulmonary artery posterior, but that's not always the case. The hearts we'll be discussing today have D-loop ventricles, or usual arrangement of the ventricles, with atrioventricular concordance. This type of transposition accounts for about 5–6% of congenital heart disease. Patients with transposition present as neonates. This is the most common type of cyanotic heart disease that presents in the neonate. These patients are blue from birth. If the interatrial communication is small, they may develop acidosis and circulatory collapse because of extreme hypoxemia. So on exam, these babies are not fully saturated. This is more apparent, of course, if one uses a saturimeter or something of that sort, but usually it's apparent to the eye. Most often, there is no murmur, particularly in patients with an intact interventricular septum. And the pulses are usually normal. There's usually not evidence of heart failure or edema, that sort of thing. The electrocardiogram is typically normal for a newborn because the right ventricle is the dominant ventricle here, the systemic ventricle, and that's what we usually see in the newborn electrocardiogram. The chest x-ray may show a narrow mediastinum because the great arteries often are more anterior-posterior located and less side by side, so the width of the mediastinal shadow is a little bit less. Pulmonary blood flow is usually normal in the newborn, but may increase relatively rapidly as pulmonary vascular resistance drops. The initial objective, of course, in our examination of the baby is to make an accurate and primary diagnosis. This can usually be accomplished with echocardiography. Here's an example of a subxiphoid view, which shows the left ventricle aligned with a bifurcating pulmonary artery here. This is a very typical appearance of the echocardiogram in patients with transposition. We scan up a little more anteriorly. We see the right ventricle here with the aorta arising anterior and to the right from this right ventricle. So this is the initial view that we would see in transposition. The other view is a short axis view or a sagittal plane view. In this view, we can see the aortic arch arising from the right ventricle. Here we saw the PA from the left. Here we see the aorta with the arch from the right. This is a large ductus in the left pulmonary artery here, but you can see the arch artery coming from the anterior right ventricle. And from a peristernal view, we can see the relative position of the great arteries. Here's the aorta anterior and to the right, with an arch coming from it with brachiocephalic arteries. Here's the bifurcating pulmonary artery posterior and to the left, typical of D-transposition. The conal anatomy can be quite variable. Usually we think of, in transposition, subaortic conus with absent subpulmonary conus. This is the opposite of what we see in the normal heart, where usually we see a subpulmonary conus or infundibulum attaching the pulmonary artery to the right ventricle and aortic to mitral fibrous continuity. But in fact, we can see any of the varieties of ventricular arterial connection in transposition. We can see just a subpulmonary conus, bilateral subarterial conus, or even bilaterally absent subarterial conus. This is an example of a typical transposition with a subaortic conus only. Here's the aorta. See the brachiocephalic arteries coming from it, the arch coming from it. So this is the aorta anterior and to the right. Here's the pulmonary artery posterior and to the left, with the right and left branch pulmonary arteries coming from it. We see the semilunar valves here. Here's the aortic valve with a coronary ostium behind it. If we look inside the right ventricle here, this is the tricuspid valve, the septal leaflet of the tricuspid valve. The aortic valve here, various leaflets of the aortic valve. And this is conal or infundibular muscle that separates the aortic valve from the tricuspid valve. So this is a complete ring of muscle, complete conus beneath the aortic valve. This is quite typical of transposition of the great arteries. Now, if we look in the left ventricle on the other side, you can see the pulmonary valve leaflets here and the medial mitral leaflet here. Free wall papillary muscles here and the smooth septal surface typical of the left ventricle. Here we see that the mitral valve is in continuity with the pulmonary valve, pulmonary to mitral fibrous continuity. There is no complete subpulmonary conus in this part. So this is the typical arrangement that we see in the great majority of patients with transposition of the great arteries. And this is an echocardiogram in a patient with transposition and a ventricular septal defect, illustrating this concept. Here's the aorta, anterior and to the right. Here's tricuspid valve here, and this is conal muscle separating the aortic valve from the tricuspid valve. On the other side, here's pulmonary valve. Here's medial mitral leaflet here, and there's fibrous continuity here between the pulmonary valve and the medial mitral leaflet. In this heart, we see the aorta here to the right, the PA here to the left. They're pretty much side by side. And that's because in this case, there's bilateral subarterial conus. Here's a ventricular septal defect seen from the right ventricular side. This is the inferior ramus. Here's papillary muscle of the conus, superior ramus of septal band, and the infundibular septum above. Here's conal muscle under the aortic valve, separating it from the tricuspid valve below. Here's the tricuspid valve down here, the anterior leaflet here, aortic valve leaflets up here. You can see a coronary ostium there in one of the sinuses. So this has a complete subaortic conus and a ventricular septal defect. Here again, you can see the coronary ostium. In this case, it's the left coronary ostium here from the left posterior facing sinus. The right coronary is arising from the right and more anterior facing sinus here. This would, of course, connect up over here. And then the non-coronary sinus is the one, the posterior and rightward sinus. So that's the right coronary sinus there. This is more like coronaries in normally related great arteries. And we see this kind of unusual arrangement in patients with unusual conus. Here's the smooth septal surface. These are free wall papillary muscles here in the left ventricle, medial mitral leaflet. The ventricular septal defect seen here, it's an outlet defect, and pulmonary valve leaflets are here. And you can see this is subpulmonary infundibulum. There's a thick band of muscle here between the pulmonary valve and the mitral valve. So this patient has bilateral subarterial conus. There is complete subpulmonary conus here as well, and this can, in some cases, cause subpulmonary obstruction, as we'll see later. This is a patient with bilaterally absent conus. Here's the aorta and the and pulmonary artery. These are the atria in the back. So we're looking into the right atrium. That's the foramen ovale, coronary sinus here. And now looking into the right ventricle. You see the aortic valve here. This is one of the leaflets. And here's the anterior leaflet of the tricuspid valve here. There's aortic to tricuspid fibrous continuity. There's no complete subaortic conus here. They're continuous with each other. There's muscle as we go toward the septum. This is septal band here. This is a little bit of muscle under one of the leaflets of the aortic valve. And if we look over toward the free wall, we'll see that the parietal band here extends out to the free wall. So there's a muscle band out here, but in the middle, there's fibrous continuity between the aortic valve and the tricuspid valve. So no complete subaortic conus in this heart. There is a interventricular communication here. It's in a bit of an unusual location. It comes up quite anterior through this tunnel-like structure here across the front of the heart and into the left ventricle. We're looking down into the left ventricle there. We look in the left ventricle, you see the smooth septal surface here. It's the left atrium in the back. Here's the medial mitral leaflet. Pulmonary valve leaflets are here, and you can see that there is continuity between the pulmonary leaflet above and the mitral leaflet below. So this is an example of bilaterally absent subarterial conus. And you can see the communication here from the left ventricle through this little tunnel-like structure from the anterior part of the heart over to the right ventricle. And in this case, there is a coarctation of the aorta and aortic arch hypoplasia. This is the pulmonary artery and ductus going into the descending aorta and severe long segment arch hypoplasia and a severe discrete coarctation in this patient. This patient has a posterior aorta and an anterior pulmonary artery, even though there is transposition of the great arteries present. These look like normally related great arteries. Looking inside the right ventricle, we see the aortic valve leaflets. There's a tiny little rim of subaortic conus here, and then the tricuspid valve just below that. This is the septal band here on the septum with papillary muscle of the conus, marking the inferior ramus there, superior ramus of septal band here, and there's a ventricular septal defect between the limbs of the septal band there. This continues out as the parietal band onto the free wall of the right ventricle here. These are aortic leaflets above the right ventricle. From the left ventricular side, we see the smooth septum, free wall papillary muscles here, the medial mitral leaflet here, and pulmonary valve leaflets above. And you can see there's pulmonary to mitral fibrous continuity here. There's the pulmonary valve coming right down to the anterior mitral leaflet. This is the ventricular septal defect here, and you can see how the mitral valve continues into the defect. In fact, it extends across, and in this case, there is mitral to aortic fibrous continuity across the ventricular septal defect. This is aortic valve leaflet inside. This is the ductus going into the descending aorta in this patient. So once we make the diagnosis of transposition of the great arteries, then the next issue is to stabilize the patient, to be sure the patient is hemodynamically stable, not developing acidosis, not having problems. And the way we do this typically is by assessing the interatrial communication and creating a larger interatrial communication if indicated, and also by maintaining the ductus open with prostaglandin to enhance left-to-right shunting across the atrial septum. By keeping the ductus open as the pulmonary vascular resistance drops, then more blood flow will go from aorta to pulmonary artery and across the pulmonary vascular bed. This increases return to the left atrium, increases left atrial pressure, and promotes shunting from left atrium to right atrium across the interatrial communication. So if the interatrial communication is smaller than usual, we would want to do a balloon septostomy. Here's an example of transposition with a small interatrial communication. You can see there's just a little flow coming across the atrial septum. Here's primary atrial septum, septum secundum. This is the foraminal valley here, and you can see there's just a small flow jet coming across the interatrial communication. So this is a patient in whom we wanted to do a balloon septostomy. This is an example of how a balloon septostomy is done. There's a wire that's come across the atrial septum here, come up the inferior vena cava, across the atrial septum into the left atrium. In this case, a sheath was put across this, although you could theoretically just put the catheter across it. This one has a sheath coming across, and then you can see the balloon septostomy catheter coming up and entering the left atrium. The sheath is then pulled back. And the catheter is out free in the left atrium. We can monitor this with echocardiography and then begin to inflate the balloon with saline. You can see the balloon starting to enlarge here in the left atrium. As this increases in size, we'll pull it back against the atrial septum, and then once it's clearly free in the atrium and snugged up against the septum, we'll pull back sharply there into the right atrium, and that tears a larger hole in the interatrial septum and improves atrial level mixing, which is the most efficient way for mixing to occur. Here you can see there's torn edges of the primary atrial septum here and a much larger communication. There's also a Chiari or Chiari network in the right atrium from the eustachian valve. And here you can see in subxiphoid view a much larger interatrial communication. The other technique that we use to improve mixing is to maintain the ductus open, at least temporarily. Here's an example of a patient with a very large ductus arteriosus, the left pulmonary artery here, aortic arch here, and you can see flow from the aorta into the pulmonary artery across the ductus arteriosus. We would like to allow the ductus to close. Here's the same ductus a day or so later that's closed. Now there's no shunting now across the ductus arteriosus. So once we've stabilized the patient and the patient is in good hemodynamic condition, then we can continue the examination of the patient, the imaging exam, usually by echocardiography, to look for other associated anomalies that go along with transposition. For example, a ventricular septal defect. We know that most patients with transposition have an intact septum, probably 50, 60% or so have an intact septum, but something like a third have a ventricular septal defect. Left ventricular outflow tract obstruction can occur. This most often occurs in the presence of a ventricular septal defect, and we can see arch obstruction. So these are the things that we're going to look for in the rest of the exam, or some of the things. Here's an example of a membranous ventricular septal defect. This is pulmonary valve. The aortic valve would be up here. Here's the septal leaflet of the tricuspid valve. This is anterior leaflet here, septal anterior commissure, and that's exactly where a membranous defect would be. And notice that shunting is from right ventricle to left ventricle because this is transposition, and the subpulmonary ventricle is the left ventricle. So the systemic ventricle is here, and shunting will be from right ventricle to left. This is another conoventricular defect between the conal septum here and the ventricular septum here. Here's the pulmonary valve, here's aortic valve. And as we watch this, you can see this is the superior-most attachment of the tricuspid valve onto the septum. That's the papillary muscle of the conus. So this marks the inferior ramus of septal band, and anything above that would be an outlet type of defect. And so here's infundibular septum. It didn't connect normally with the superior endocardial cushion here, and with the rest of the muscular septum. So it's deviated out anteriorly in this case with an overriding pulmonary root. This is pulmonary valve, this is aortic valve here. So this is an outlet conoventricular type of defect with an overriding pulmonary root. Here's the same thing in short axis. Here's tricuspid valve. Here's the papillary muscle of the conus. Here's infundibular septum up here with pulmonary valve here, aortic valve here. And as we scan toward the apex, you can see how the infundibular septum separates from the rest and in fact is out under the aortic valve. And this is the kind of BSD where we sometimes see a coarctation of the aorta. We can see muscular ventricular septal defects. Here are a couple of muscular defects here in the mid-muscular septum. You can see again they're going from right ventricle to left ventricle because this is transposition, and the left ventricle is the subpulmonary ventricle. This is just another larger muscular defect. There's some defect up here. It extends down into the inferior septum down here as well. So this is a very large, complex mid to apical muscular ventricular septal defect. This is another conoventricular defect. In this case, this is a posterior malalignment. This is the opposite of what we saw before where the infundibular septum was over the RV. Here it's back over the LV. And the aorta is quite close to the defect. This is the left ventricular outflow tract here. And will turn into an apical long axis view where you'll be able to see this better. Here, there's pulmonary valve. This is infundibular septum. And you can see the narrowing in the subpulmonary area. This is the ventricular septal defect with aorta here. So this is subpulmonary stenosis from a posterior deviation of the infundibular septum. We can see this actually better in a parasternal long axis view. This is left ventricle, right ventricle. Aorta is here, and this is the left ventricular outflow tract pulmonary valve. This is infundibular septum, which is deviated posteriorly over the left ventricular outflow tract, causing left ventricular outflow tract obstruction or subpulmonary obstruction. You can see pulmonary valve leaflets here. The annulus is a bit small, but most of the obstruction is down here between the infundibular septum and the medial mitral leaflet. So this is probably the most common type of fixed left ventricular outflow tract obstruction that we see in transposition. And this is an example of that. This is aorta. The pulmonary artery is here all the way in the back and quite small in this case. This is pulmonary. In the right atrium, you can see there's a foramen ovale here. The right ventricle, there's a ventricular septal defect that's pretty large here. This is the papillary muscle of the conus and the inferior ramus of septal band. The superior ramus is here, and the body of septal band going down the septum here. So the defect is between the limbs of septal band and here. This is a typical position of an outflow defect. This is infundibular septum underneath the aortic valve leaflets. See all the leaflets here. Here's a coronary ostium and the other part of the leaflets. Now, here's one of the coronary ostia right here. That's the right coronary ostium. The left coronary ostium is in this sinus. It's there, right there. It's the left coronary ostium. So those are the two facing sinuses. Here's our left ventricle with smooth septal surface, ventricular septal defect there. Here's the papillary muscles on the free wall of this left ventricle and the medial mitral leaflet. And notice these are pulmonary valve leaflets here. And this is the infundibular septum, this fibrous ridge here that's extended back over the left ventricle and causing subpulmonary obstruction. This is the narrowed pulmonary outflow tract with thick pulmonary valve leaflets, possibly from the buffeting by the jet through the subpulmonary obstruction, and a small pulmonary artery back here coming from that. Here's our pulmonary artery with branches and the ductus arteriosus going to the descending aorta. This is another cause of subpulmonary obstruction. We don't see this much anymore because most patients get operated before they actually develop this. This is an aneurysm of membranous septum, and this is the aneurysm right here. It's extending into the left ventricular outflow tract here. The pulmonary leaflets are up here. This is the medial mitral leaflet here, and this little aneurysm is extending through this ventricular septal defect and causing subpulmonary obstruction. This is it in subxiphoid view. You can see the pulmonary leaflets moving way up here. This is the aneurysm that's extending back. Here you can see it better in this apical view. This is the aneurysm extending back into the left ventricular outflow tract, causing narrowing here between it and the medial mitral leaflet. This is can generally be treated during closure of the ventricular septal defect. If you see one of these, it's just a matter of taking the tissue of the aneurysm, which is here, and just pulling it back into the VSD and including it in the suture line. That prevents it from billowing out into the left ventricular outflow tract and treats the subpulmonary obstruction that we see here. This is an example of that. We saw this heart before, but here is the medial mitral leaflet here. Here's the pulmonary valve leaflets, and here's this little aneurysm of membranous septum. There's a membranous VSD associated with this, but you can see how this is bulging out into the left ventricular outflow tract. And if we took this edge and put it back to this edge, as it would be in the normal situation, this would come up against the medial mitral leaflet and cause subpulmonary obstruction. Another cause of left ventricular outflow tract obstruction is the persistence of subpulmonary conus, the so-called left conoventricular flange that we see here. It's also called the muscle of Muller. And in this case, it comes up very close to the anterior muscular septum here. The pulmonary artery is up here, the aorta is over here. This is the infundibular septum and anterior muscular septum, and you can see how this comes up close to that and causes narrowing here toward the pulmonary outflow. This is not a papillary muscle, it's just a muscle bundle. It's the residual conus under the pulmonary artery there. There's the jet of the subpulmonary obstruction. And so this can be resected without any problem. There are no papillary muscle associated with it and no mitral valve attachments to it. So this can be resected, and that can relieve the subpulmonary obstruction. Patients like we saw earlier with the anterior deviation of infundibular septum in particular can have coarctation. And here you can see a somewhat narrow transverse arch here. The isthmus is here. There's the subclavian artery. And this is a discrete coarctation. There's subclavian artery there. This is a discrete coarctation here, a large ductus here coming into the descending aorta. So severe discrete coarctation and some arch hypoplasia in this patient. Another example of coarctation. Here's the ductus in this patient. It's closing. You can see the walls are thickening here. There's some narrowing here at the aortic end. It's still open at the pulmonary end. And this is the coarctation here, right there at the proximal edge of the ductus. There's again some arch hypoplasia. You can see a little thrombus probably here in the ductus right there that's contributing to closure of the ductus. So this is another patient with transposition and a coarctation of the aorta. The arterial switch operation, of course, is now the treatment of choice for transposition of the great arteries. So coronary artery anatomy turns out to be important, and we can usually see this with echocardiography. This is an example of the most typical type of coronary anatomy, what we call usual anatomy in transposition. This is probably present in 80–85% of patients with transposition. And here we see the left coronary coming from the left anterior facing sinus with the bifurcation, the right coronary here from the right posterior facing sinus, and the pulmonary artery over here. So the two facing sinuses are the ones that are adjacent to the pulmonary artery, and that's where the coronaries typically come from. The non-coronary sinus is the one away. It's usually the anterior sinus in transposition. So here's an echocardiogram, a short axis parasternal view that shows the left coronary coming out like this, up here from this left anterior facing sinus. Here's the PA in the back. So this is a short axis view. Now if we turn into a long axis view, you can see the coronary artery bifurcation here into a circumflex and an anterior descending. Here's the left main, here's the anterior descending, here's circumflex. So this view is useful for seeing a little bit more of the anatomy, and then back to a short axis to show the right coronary here coming out of the right posterior facing sinus of Valsalva. So this is the usual anatomy, the most common anatomy that we see in transposition. And this is an example of that. The aorta, of course, is here, anterior and to the right. Pulmonary artery here, posterior and to the left. This is aorta here, PA. And you see the left coronary here arising from the left anterior facing sinus. This is the left main. And here's the bifurcation with the circumflex going back behind the left atrial appendage, and the anterior descending here, and a big ramus intermedius branch. The ramus branch is fairly common. You can see this then supplies the anterior interventricular groove in the anterior free wall of the left ventricle. Now turning back to the right posterior aspect of the aorta, we see the right coronary coming. This first branch is the sinus node branch. Then we have a preventricular conus branch here supplying the subaortic conus. And then the right coronary going around in the right AV groove toward the posterior descending. Looking inside the aorta, you can see the two coronary ostia. Here's the right, here's the left. They're coming from the two facing sinuses, the ones adjacent to the pulmonary trunk here. And if we look down inside, you can see this is the non-facing sinus, the non-coronary. This is left coronary, that's right coronary sinus. And these are just slightly above the sinotubular junction, as you can see here. The most common variant of coronary anatomy that we see in transposition is when the circumflex coronary comes from the right coronary and the anterior descending arises by itself. This occurs in maybe 10–15% of patients with transposition. So here's an example. Here's the right coronary and the circumflex coming from it proximally here and going behind the pulmonary trunk to reach the left AV groove. And there is the anterior descending here coming out in the usual left coronary position and just supplying the anterior interventricular groove. So this is the most common variant. In a subxiphoid or apical view, we can often see the circumflex coronary here behind the pulmonary trunk. We're following it here as it's going behind the pulmonary trunk and just in front of the mitral valve, which would be down into the left ventricle here. There's pulmonary trunk as we scan up. And sometime, here's another example. This is the right coronary and the left circumflex coming from it. You can see there's a very short right main before the branch of the circumflex. And then it will go behind the pulmonary trunk here to reach the left AV groove. This is an example of that in a specimen. Again, this is aorta, pulmonary artery. They're more side by side here. Aorta here, pulmonary artery here. We see a little bit more side-by-side great arteries when there's unusual coronary anatomy. And this is the anterior descending coming from the left anterior sinus, the usually left coronary sinus, but here it's just the anterior descending that's coming down the anterior interventricular groove, and we don't see a circumflex artery coming from it. Now, if we tip the aorta anteriorly here forward and look behind, that's where the right coronary comes from. Here you can see the right coronary. Has a conus branch here. It has the right main branch here going back to the AV groove, sinus node artery. And then there's the circumflex artery, the left circumflex artery coming from the right coronary. And you can see it here. This is the left atrial appendage here, so it's running underneath that. And this is the circumflex artery here as it comes around and goes in the left AV groove to the back. So this is origin of this left circumflex from the right coronary. Another relatively frequent variant that we see is when both arteries, either separately or as a common ostium, arise from the right, usually right coronary sinus. And there's often a tiny infundibular branch or conus branch that comes from the usual left coronary sinus up here. And then the left coronary goes behind the pulmonary trunk like we saw the circumflex before, and then bifurcates out here. This is a subxiphoid view of this. Here's the aorta, PA over here. And here you can see again the two arteries, the right and the left, coming from the aorta, from the posterior aspect of it. And here's the bifurcation of the left out here. And it's going behind this pulmonary trunk. There are the two great arteries coming from the single posterior. And in a parasternal short axis view, you can often see the left coronary behind the pulmonary trunk. And here's this little conus coronary coming from the usually left coronary sinus up here. That often has to be moved as well. This is, no, it's not going to play, but anyway, both of the great arteries come from this posterior sinus back here. We can also see much more rarely a single left coronary that arises from the left anterior sinus, with the right being the first branch crossing in front of the aorta to get to the right AV groove, and then the anterior descending and circumflex. This is almost like a trifurcation of the great artery, of the coronary artery here. Here's an example of that. Here's the left coming out of the left sinus, PA back here, aorta up here. And this is the right coronary going back in front of the aorta, anterior descending and circumflex, like a trifurcation here of the coronary artery. This is looking at it in that long axis view and then back to short axis. So this is a typical single left. One of the important variants, maybe the most important variant for us to recognize ahead of time, is an intramural coronary. Usually when that happens, it most often involves the left, and when there is an intramural segment, it usually takes origin from the opposite sinus from normal. It usually originates from the right coronary sinus back here with the right coronary artery, and then there's a segment of the artery that runs within the wall of the aorta before it exits from the adventitia. This is an example of that. Here you see the right, the left. This is where that commissure is, that usually is the intercoronary commissure. So this has just made it over into the right coronary sinus. And you can see there's a segment of the artery right here that runs within the aortic wall before it exits out here. So again, a little intramural segment right here, this part. See if we can see that a little better. There. So there's a thin wall up here between the coronary and the aorta. And here, this is the endothelial origin or ostium of the coronary. Then there's a little segment that runs in the wall here. And then this is where it exits the adventitia. So it's this segment here with a very thin wall between the aorta and the coronary artery. That's the intramural segment. This is another example of a patient with a little bit longer segment. Here again is the usually left coronary sinus over here. Here's the right coronary, and here's the left coming across and originating from the right coronary sinus. The commissure is here. So you can see this is the segment that's within the wall right here, thin wall, and then it exits the adventitia out here. So there's a longer segment. And you can see the bifurcation is pretty far out here. Here's circumflex anterior descending. So this is an intramural. It's uncommon, but we occasionally see also an intramural right coronary. This is an example of that. Here's the right coronary, here's the left. This is the left coronary sinus. This is the usually right coronary sinus, but there's nothing coming from it. The right goes in the wall of the aorta and originates from the left coronary sinus over here. So this is the intramural segment here. So we can see an intramural right coronary as well. The treatment for transposition is one to stabilize the baby, as we said before, and this often involves a balloon atrial septostomy. Not everybody needs this. Patients who have a sizable interatrial communication may not need a balloon septostomy, but patients with a quite restrictive interatrial communication almost always do. And this can be performed easily either in the ICU or in the cath lab, depending on the preference of the operator. We also, as we said, typically start prostaglandins to improve mixing at atrial level in these patients. We would like to stop the prostaglandins prior to surgery, but that's not always possible. The arterial switch operation, of course, is the treatment of choice for the great majority of patients with transposition. And this is usually performed in the first week or 10 days, but certainly within the first 3 or 4 weeks of life, we would like to get this done. Some patients with fixed left ventricular outflow tract obstruction are more amenable to either a Rastelli type of repair or a root translocation with a conduit from right ventricle to pulmonary artery. This depends on the exact anatomy of the outflow tract and really has to be decided largely on a case-by-case basis. The outcome for simple arterial switch operation is very good, both medium and more long-term as well. We know that there is an incidence of coronary stenosis or occlusion. Maybe 5–8% of patients actually have stenosis or occlusion of one of the other coronary arteries. These are longer-term data from Children's Hospital from the adult congenital program here. These are patients with transposition with intact septum. And these are patients with transposition with VSD, and these were double outlets. So they're a little bit different arrangement. So we're going to talk about these two. And you can see that we still have a good number of patients even out to 20 years after surgery. And at that point with intact septum, you can see that the freedom from reintervention is about 85%, and it's about 75% for patients with a ventricular septal defect. So most of these patients do very well, even out at 20 years, and don't need anything else done. Most of the reinterventions here are for pulmonary stenosis or aortic insufficiency or something of that sort. There is an incidence, and it seems to continue out to 20 or more years of sudden unexpected death and arrhythmia. This is a combination of recognized arrhythmia and sudden death. So it isn't all sudden death. Most of this, in fact, is just arrhythmia. But we know that these patients do get arrhythmias, but this is much, much lower than the prevalence of arrhythmias that we saw in patients after an atrial switch operation. This is only about 5% at 20 years, 5 or 6%. So that's much lower. By 20 years, virtually everybody with an atrial switch operation had either sick sinus syndrome or atrial flutter or some other kind of atrial arrhythmia. These, again, are data from other programs. This was published in 2011. And you can see there was an early loss of patients, probably perioperative, but after that, you can see that the curve flattens out. And here we have a reasonable number of patients out 15 years. And again, you see about 85% or so overall survival at 15 years. This is freedom from reoperation, and also at 15 years, we see about 75% freedom from reoperation. Not so different from what we saw in the other series. Most of the reops here were for right ventricular outflow tract obstruction, with some for aortic insufficiency. These are fairly long-term data from Marie-Lannelongue Hospital in Paris, where they started doing arterial switch operations relatively early. This was based on a group of patients who underwent surgery up till about, I think it was 2015. There were 308 operations. These were all complex switch operations. That means VSD, left ventricular outflow tract obstruction, right ventricular outflow tract obstruction, coarctation, some other complicating feature, not just either a VSD or intact septum. So there were 42 operative deaths for about a 13-14% operative mortality. And then another group of patients were lost to follow-up because they were international patients. That left 220 patients that they were able to follow. And so that's the cohort here that's being reported on. And you can see that there's still almost 50 patients out at 20 years. So this is reasonable data, and 96% survival of the operative survivors at 20 years. So the late loss of patients here is very low in patients after an arterial switch operation. The reoperation rate is a little bit higher, as you would expect. We look again out at 20 years, the freedom from reoperation rate is about 70-75% of these patients, which is similar to what the Children's Hospital data look like. And most of these were aortic valve surgery, either a repair of the aortic valve or replacement, right ventricular outflow tract obstruction or peripheral pulmonary stenosis. And some of these patients had recoarctation, and that was the reason for reintervention. The freedom from neo-aortic regurgitation at 15 years was about 90%. And this is having grade 2 or less aortic regurgitation. So really pretty good function of the aortic valve out to about 15 years. This is a study from patients with fixed left ventricular outflow tract obstruction who underwent an arterial switch operation. And they were able to show that patients who had a pulmonary valve annulus Z-score that was greater than 1.7 had almost no reintervention, no residual left ventricular outflow tract obstruction, whereas patients who had a smaller valve annulus, less than a Z-score of minus 1.7, had about a 70% freedom from reintervention. So about almost a third of these patients underwent either reintervention or had significant left ventricular outflow tract obstruction. And freedom from aortic regurgitation looks pretty similar to what we saw in the other series, with about 85-90% freedom from significant aortic regurgitation at 10 years. So this is a review of transposition of the great arteries, the anatomy, the treatment for transposition, and some of the outcomes that we see.